All right, hi. It's a real pleasure to be here with you guys today. My name is Nick Sawyer. I am an assistant professor of emergency medicine here in the Department of Emergency Medicine. I am also the fellowship director for our Health Policy Fellowship. I got a 5-year combined MD MBA when I went to UC Irvine. I then continued on to do my emergency medicine residency at Carolinas in North Carolina. Came here and completed the fellowship that I'm now in charge of. And a long time ago, I decided that the best way to help the greatest number of people is to attack it from a big systems level. So it's almost like if you think about research. I had a professor one time say, I do this research because I'm a GI doctor, and if I see 15 patients per day, 5 days a week, then maybe I'll help 80,000 patients or whatever in my life. But if I do some research and I uncover something that can be really useful, then I could potentially help millions and millions of people that I will have never met. And I'm not a researcher in that type. I don't like bench research, but I'm very interested in politics and policy. And so the way that I decided to make a greater impact, rather than just caring for patients one-on-one, was to get into the policy realm. And so I am here today and for the next 4 weeks to convince you guys that this stuff is important. And it is very important. And part of my job is to show you that today. So we're going to start off in 1905. There we go. So you can tell it's a very lively event. We are at the House of Delegates for the American Medical College in Portland, Oregon. And they have appointed the Council on Medical Education for the first time. And the Council on Medical Education has been tasked to come up with some formal recommendations about medical school and how medical school should be formatted. And so they came up with their recommendations, and this is the first time that they are presenting it in front of the House of Delegates. And so it goes something like this. Your committee believes that, in addition to a well-balanced medical education, the welfare of the future practitioner demands that he should have some business training, a broad conception of the principles of medical ethics and of the value of medical organization in the promotion of scientific work, social intercourse with his professional brethren, medical legislation, and political action. Your committee recommends, therefore, that in the construction of a standard medical curriculum by the council provisions be made for a distinct and complete course on business methods for the practitioner, on medical ethics, and the value of medical organizations. Respectfully submitted, the Reference Committee on Medical Education. So, in 1905, before Flexner, before they came up with this formalized 2+2 curriculum, 2 years of basic sciences, 2 years of clinical science, they had this reference committee and they said, we need to go beyond that. We need to think about business. We need to think about ethics. We need to think about political advocacy. We need to think about organizing. And the response from the chairman of the Council of Medical Education, that was a reference committee, came back and said, no. The ideal standard to be aimed at, from our present viewpoint, should consist of a 5-year course. The first years which should be devoted to physics, chemistry, and biology. Of the 4 years in pure medical work, the first 2 should be spent in the laboratories of anatomy, physiology, and pharmacology, and the last 2 in close contact with patients in dispensaries and hospitals, in the study of medicine, surgery, obstetrics, and the specialties. It is not believed that the time is ripe to discuss the many other interests and important subjects included in the broad questions of medical education. and they ask for approval of the report. It gets approved, and the idea of having this additional education is sort of sandbagged for the next 100 years. So for the past 100 years, we've had this two-pillar model. It's basic sciences and clinical sciences. That's what you guys are doing right now, sort of, because we're here doing this. That's what I did. That's what all my colleagues did. That's what all my attendings did. And so what is that? Where does that let us? What does that mean? Why do I care? Why do you care? Why should you care? And the reason is that in the center, you can see there's the doctor-patient relationship. And through the lack of understanding of business and health policy and economics, there's created a power vacuum in medicine. And this power vacuum has been filled by leadership in business executives and politicians. And if you've ever spoken to, if anybody ever done any advocacy work and gone and talked to legislators on the Hill, a few, how much do they know about medicine? Virtually nothing, literally. My mentor, who I took the fellowship, well, who I work with on the fellowship now, her name is Amy Mullen. She does a lot of great work. And Amy says that the legislature is an information-free zone. It's true, to an extent, because stories are what matter. They don't want to hear a bunch of facts and figures. It's the stories that really grab these people, because they don't understand what we do. And so, as we have fallen behind in creating the different structure needed to create a patient-centered healthcare system, it's been filled by people who don't actually know what they're doing. And as soon as you guys get into practice, you're going to realize that real quickly. You guys, if you read the news at all, you'll recognize that already. It's very, very apparent. So what do we got? We got a bunch of industries. We got the health insurers, medical device manufacturers. We got these things called pharmacy benefit managers. We got pharma, got medical device manufacturers, the people who make our EHRs, and they're all surrounding the patient-doctor relationship. The question is in this environment, if all of these companies are working in order to make profit, then who's looking after the patient? Who's looking after the doctors? Do you guys know this term fiduciary? It's a legal term. So fiduciary responsibility is that you have a legal responsibility towards somebody. And when companies are publicly traded on the New York Stock Exchange, they actually have fiduciary responsibility to their shareholders. And if they don't do what's in the best interest of raising that shareholder price, then their shareholders can sue them. That happened with Elon Musk when he went on Twitter and said, I'm going to take my company private because I'm high. You guys, did you see that? Yeah. So that's created, like I was talking about, this organization where we have this set of industry around us and our patients who aren't primarily interested in what's best for the patients or what's best for us. They're interested in what's best for their shareholders. In my opinion, I've written this before, but I think that that's antithetical to a healthcare system. Here's some examples. So here's a $91 million case against the nation's largest insurer. That's a clear win for patients. Here's a jury delivering a $25 million settlement to Aetna to change its ways for its bad behavior. Here's an example of while our patients in California on Medicaid, on Medi-Cal, are waiting 2 months to get a primary care appointment, the insurance industry is making billions of dollars off of it by basically preventing care. That's very real. As an emergency physician, I see it all the time. And through your United experience, you're going to see it too. Here's an example of what's happening right now with private equity firms who are buying up physician groups and then overcharging. And the physicians are innocent in this example, or in these examples. Some of them are getting bonuses for doing the things that the private equity firms want them to do. That's wrong, period. That's wrong. Here's just a few more examples. I could go on and on and on and on, but I won't. But here's an example of the opioid epidemic. So you guys know that Purdue Pharmaceuticals, the maker of OxyContin, just offered to settle $10 to $12 billion for their role in inciting the opioid epidemic. Did you guys know that? You know they made $35 billion off OxyContin? That's wrong. This is from the Department of Justice. This is a U.S. attorneys who charged one of the CEOs of Insys, who made a opioid for racketeering, the RICO Act. That was made to penalize and indict criminal organizations, organized crime, the mafia. Insys was charged with that. It goes on and on. So the question is, first is ethics. You know, in that report it said, one of the things that they talked about was we recommend this training in ethics. Because who else is going to look out for the patients? Who else is going to look out for each other? Us, right? And so, as a guardian of our fellow citizens' health, we have a fiduciary responsibility to do what's right. And I know that the way that you guys are recruited here to UC Davis is that you guys are usually have very high standards when it comes to morals and ethics, and I really like that about working here. But it certainly doesn't go. It certainly does not go across the table nationwide. And so, there's a few things I want to start off with. Is integrity. Doing what's right when no one else, even when nobody else is looking, right? The next one is to be humble. So this is great. I was a medical student, and I was at the Long Beach VA. I was sitting around a table with a bunch of detoxing veterans, and there was this guy who was himself a prior alcoholic, and his name was Randy. And we're sitting around, and he goes, "What does it mean to be humble?" It says, it's the ability to remain teachable, right? That's a big deal. You don't want to be like somebody who thinks that they know everything all the time. Doesn't make for good relationships with your colleagues. Doesn't make for good relationships with your patients. Morality, understanding right and wrong, bad behavior. Not lying. And empathy, big deal. Empathy. Do you think the policymakers right now in Washington have any empathy for the patients that they're trying to take the Affordable Care Act away from? Does that seem very empathetic to you guys? No. So again, we're the doctors. It's our role to be empathetic. It's our role to put ourselves in the shoes of others and understand what it is that they're going through. So, fortunately, 100 years later, we have this new educational model. It's called health system science. And it is considered the third pillar of medical education. It was in 1905 when they introduced it. They got swept under the rug, and now look where we are. So it's coming back. And it's of great interest to me. And I hope it's of interest to you guys, if for nothing else, that we really need to develop physician leaders. We need some, if not all of you, to engage at any level, whether it's local, state, national. And I would love it when you guys went to the Senate one day. Became president. Who knows? But we really have to, I'm here to convince you guys that this stuff is important. And yes, I understand you guys have step one coming up. I took step one. It's a beast. You guys will be fine. I promise. Additionally, there is some health system science concepts that are on step 1, and I actually have that information that I can provide to you guys. It is about 8% of your tests. I don't have the questions, or do I? But it's about 8% of your test, and it's going to grow because of the importance. Everybody in medical education thinks this is important. This, I don't want you guys to get freaked out about at all. I just want you to sort of look at it real briefly. This is the entire framework that was set forth that says, what is health system science? What are all the domains and subdomains? This is in your syllabus. Hoping that you will take a look at it later on, just so you understand the different types of things that are covered underneath it. And each one of these are addressed in the book that I'm sure all of you bought. But there are available copies over in the library. It's actually it's really well written. So some things I want to talk about before we get into the details of United is some big overarching health system science themes. Is the quadruple aim. Has anybody heard of the quadruple aim? You heard of the triple aim? Who's heard of the triple aim? All right. So what is the difference between the triple aim and the quadruple aim? Is it number 4? What is number 4? Yeah, that's exactly right. So when the IHI came out with the triple aim, it was a laudable goal, and it said that we need to improve patient experience, we need to improve population health, start to think about the system and the way in which we deliver care, and we need to think about reducing costs. And for a while, we were like, yeah, this is fine. But then we got burnout, right? You guys heard of burnout? So burnout is multifactorial. We can talk about burnout at length if you guys want. But with the first 3 pillars or tenets of the triple aim, with the focus on these things, it's all sort of like, what more can you do, doctor? And so finally they added that 4th pillar. And that was really recently. That was actually in 2014. So that's a quadruple aim, and it is a good goal, and we should be aiming towards that. So then what is value in healthcare? What does it mean to provide high-value care to your patients? And so really, in the simplest form, it's just quality over cost. Anything that you can do to improve quality for patient care is going to improve value. Anything that you can do is to decrease cost is going to improve value. And the quality includes outcomes and patient experience. I'm not going to harp on that too much, but that overall is the value equation in healthcare that you guys should be very familiar with. So the course structure. So yeah, we piloted this in 2016. And this is the 4th year we're doing it. It's the 2nd year we're doing it with the entire second medical student class. And it's gone well. I really enjoy it, and the students have enjoyed it. It makes me very happy because that's the reason I'm here. And so the whole idea is to have you guys speak with patients in our emergency departments to get an understanding of what it is like to be a patient in our U.S. healthcare system. So yeah, it's 4 parts. Orientation. Congratulations. Y'all made it. The second part is the emergency department experience, which we'll talk about. The third part is is a written reflection, which is sort of like a I feel sort of thing. It's pass-fail. You're all going to pass. And the last one is team oral presentations. And this is new. And the idea of the team oral presentations is not to overburden you guys with work. But the idea is that prior to this year, we got a lot of feedback, and the feedback went like this. Wow, Dr. Sawyer, everybody's really good at UC Davis about telling us how much the healthcare system sucks. How about helping us out with some solutions? Oh yeah, okay? That's a very, very good point. And so with these team oral presentations, we're going to work on thinking about solutions. And we're actually going to think about working on solutions in a particular strategic manner. That's been adopted by the leaders in health system science who I revere. So let's start with the emergency department experience. So y'all have your schedules, and you're going to meet me and our current health policy fellow and/or our current health policy fellow, Dr. Taylor Nichols, outside of the emergency department. And some of you guys will meet at 4 and go till 7. Some of you guys will meet at 8 and go to 11. Don't bring anything valuable to the emergency department. We bring valuable stuff to the emergency department, but we understand the risk of getting stuff stolen. You can bring food and something to drink, but it's only 3 hours. I mean, you guys are going to go without eating for days in residency, maybe? I don't know. Obviously not. Dress code, business casual. Business casual, what does that mean? There's a link in the syllabus that will take you to this article that I found on business casual. I know what business casual is because I went to finishing school and business school. They taught me how to use like the right fork and stuff. But really it's for guys, slacks. It's shirt, no tie. For women, blouse, pants, or skirt. Don't wear your white coat. Don't bring your stethoscope. Wear your name badge. This is not a clinical experience in the sense that you are not providing diagnostic and therapeutic treatment for your patients. This is totally different than that. And so we don't want the patients to think that you're a member of the care team. And bring something to write on, to take notes. This is a lot of words. You don't have to read it. Busy slides, like, get it. You guys should get this too, actually. Busy slides are a big F. But the point of this slide is that there's a very particular way that I introduce what we're doing to the patients in order to recruit them into speaking with you guys. And so I try and find the patients and I say to them, hey, my name's Nick Sawyer. I'm attending here and I'm interested in policy. And I'm interested in teaching the future generation of doctors about what it's like to be a patient in the healthcare system. And I was wondering if you'd be willing to speak with them about your experience so that hopefully maybe you can tell them some problems that you've had and that they may one day be able to go on to fix those problems to make the system better for all of us. And sometimes the response is, no thank you or whatever it may be. But other times, patients are really interested in giving this type of feedback. We've had some very, very cool patients sort of light up when they hear this because they get to talk about, air their grievances, and it's our job to be there to listen. There's a couple things that I want to talk about in terms of when you're talking with patients. There's 2 things. The first one's called reflective listening. You guys have probably heard of this one, right? So patient says something, you repeat back to them. Well, so I just want to make sure that what I'm hearing is correct. It sounds like what you're saying is that you're having a difficult time getting to your appointments and refilling your medications because you don't have transportation. Is that correct? Yes, that's correct. The next one is called humble inquiry. I had never heard of this until I went to some teaching course. And this is very cool. The fine art of drawing somebody out, asking them questions to which you don't already know or could not possibly know the answer to. I like the thought of that. This is your opportunity to ask questions of these patients in a respectful manner to learn about them, to learn about the struggles that they go through. So, reflective listening, humble inquiry. This is part of something called ethnographic observation. And the idea of ethnographic observation, so is it's immersing yourself in a culture and getting an understanding of what it means, what that culture means. What is the context in which that culture exists? What are the relationships between the people in that culture? How do they feel about the medical system? How do they feel about their providers? How do they feel about their own health? What is their understanding? What does their health literacy look like? And so this is a form of ethnographic observation that we're doing. And this is mostly an academic sort of thing that I'm providing to you guys just so you have heard the term before, but it sort of exists within what we do already. But it's a very good way, actually, to come to conclusions on how you can reach solutions, patient-centered solutions, through ethnographic observation. Is sometimes people will just go to an area and just watch the environment in order to understand what's going on without even ever talking to anybody. And then come back with a report and say, this is what we saw and this is what we took away from it. Next concept I want to talk to you guys about is systems thinking. So that's a big concept in health system science, is understanding how each individual part plays a role as part of the bigger picture. How does it fit in? What are the inputs and outputs? What are the consequences of the systems levels decisions on the problem that you're looking at right now? So we want to understand, how is it that this type of legislation is impacting this patient, right? Or how is it that our hospital system is impacting this patient? Thinking about the bigger picture, which is sort of a shift in the way that we ask you guys to think about medicine, from discussing patients, talking to patients one-on-one, getting a history and physical examination, a brief social history, and then performing some diagnostic examination, labs, imaging, whatever it may be, and then coming up with an assessment and plan. But we want you to think about things like, wow, I came up with this assessment and plan, and it's really good because I'm really smart, but can my patient follow through with this plan? Can they afford these drugs? Do they have the insurance to actually follow up with these providers? Those types of questions matter, and they're important. And if we are going to take back the reins of healthcare and be patient advocates, then we can't just brush this off any longer, because nobody else is doing it for them. And they certainly don't have the knowledge or skills in order to do it themselves. It's really just all about the linkages and interactions between the components that make up the system. One of the final, we're getting towards the end here, but one of the final concepts I want you guys to think about is design thinking. Design thinking comes from business. And the whole idea of design thinking, does anybody know what design thinking is or have heard of it before? Read Tim Brown's book? Anybody, do you know? Shoot.
The idea is like, come up with just a ton of stuff and post-its involved.
Yep. Yeah, there are post-its involved, that's right.
Like tear it down. Prototype, like make a shitty prototype.
Yep. Thank you for cursing, I like that. I'm dead serious about that.
And eventually you produce this theoretically something useful.
Yeah, that's, so yeah, it's this iterative approach to a problem, and there are post-its involved and shit. And the idea is that it's beyond that, though. It involves a number of things, but really what it thinks about, is anybody like a Apple person? Y'all got laptops. Did anybody order the iPhone? Is it just me because I'm an attending? Are you like an Apple fan? Are you an Apple fan? Wait, did you work for Apple? Okay. Did anybody watch Tim Apple? Tim Cook. For the iPhone 11 launch? Did you guys watch it? No? I watched it. I always do. I love that stuff. I have a green iPhone coming. The lenses, I'm really excited. So, all right, hold on, we're almost done. What is it that Tim Cook came out and talked about? The very first 3 sentences that he said when he walked out there and talked about the new iPhone 11. Does anybody know? He said, we worked with customers to determine what it is that they want and what they need. 3 cameras. 4, I guess. Somebody wants 4 cameras. But that is really the focus of design thinking, is speaking with the customer, in our case, our patients, and getting an understanding of what their needs are and how we can best fulfill those needs, and getting their input. I see you have this problem. What do you think is the best approach to fixing this problem? And it addresses, so that's what it says here. But it addresses, we want to address 3 things when we're considering this. Is we want to think about the feasibility of the idea, which is what's functionally possible, the viability, what's sustainable, and the last one is desirability. What makes sense to people and for people. So when you are talking with patients and they're telling you about their problems, I want you to ask them, what do you think is the best way to solve this problem? Because by integrating our patients' thoughts into it, A, we're going to hear things that we could have never possibly imagined. And B, we're going to hear potentially some really good ideas. Probably some really bad ideas. We're going to hear all kinds of stuff. But the idea of integrating the customer's ideas into the solutions is a big part of design thinking. So, the reflective writing assignment. Here it is. You can think about this before you come to the emergency department. 500 words, about, more or less. Answer the following questions. What surprised you about the experience? And what did you learn? How will you apply it in your clinical years? So that's a pass-fail assignment. Just give you a chance to reflect on what it is that you saw, heard, and learned. The team oral presentation. So what's going to happen is y'all are going to come to the emergency department and meet me and or Taylor. And there's going to be 4 of you. And we're going to divide you up into groups of 2. And you'll see patients together in pairs. And near the end of the shift, we're all going to sit down. We'll have all 4 of you, and then me and Taylor. And we're going to talk about what you heard, what you learned. What are the stories that were told? And from that, we're going to pick a topic. We're going to decide on a topic together that you found most interesting or most intriguing, or you just wanted to learn more about. And we're going to help guide you with this. This is not like, go figure it out. Like, we're content experts in this. We love this stuff. I have 1 trillion articles in my Pocket app. You guys use Pocket? Dope. So we're going to help you with that. And we're also going to guide you towards like the really high impact stuff that makes the most sense to look into. There we go. You got to use it. It's got to be a PowerPoint. The PowerPoint's been uploaded. If you go to the team oral presentation assignment, there's a thing that says, please use this PowerPoint. It's limited to 10 slides, not including the title slide that has your name and the title of the presentation. And then you're going to have 10 minutes to present. And what we want you to do is discuss this care gap, this unmet need that you heard from your patient, and that we decided as a group that y'all were going to look into, whatever that may be. And we want you to approach it in a particular way. And so there's a lot of words up here. But the reason is because we want to make sure that this is helpful, and we're not just like, do a presentation. We gave you guidelines to follow to make it easier. And so the idea is that you're going to start off with a brief history of the patient. And then you're going to do a little bit of research into that topic. And we want you to have just 2 citations, one from a journal and one from the popular press. Chances are I will give you the article from the popular press. And then we want you to also actually use the textbook. The textbook's really good on a lot of this stuff, and we'll give you the fundamental understanding of the things that you need to know if you know zilch about this topic. And so the textbook's very good for that. That does not count as a citation. And then using a patient-centered and design thinking approach, like we talked about, including the patient input, thinking about desirability, feasibility, and viability. We want you to talk about 1 to 3 countermeasures. What is it that we can do? What did the patient say? What's going on already? Is there something out there that's going on that is a great fix, but that has reached some barrier? We want you to talk about why. You guys don't have to come up with like these de novo ideas, but you might, or the patient might just tell you. And then if that is the case, then yeah, why it hasn't been implemented. That's weird. Like I said, y'all have 10 minutes to present, 10 slides. Use the template, please. Everybody's going to stand with the group. And there is a rubric for this. Makes it easier. You follow the rubric, get 100%. That's up on the writing assignment too. It basically just says everything I just said. Try not to make this too hard because we really want you guys to be engaged in this. There is something that I didn't have time to put into my slides. Okay. There's also a second component to this, which is called UQuick. It's actually a new curriculum after last year's debacle of trying to start a quality improvement in patient safety experiential learning curriculum, which I tried to do in the emergency department, but it turns out that it's very hard to do that in the emergency department because it requires that you talk to a number of people in the emergency department, and they're very, very busy. So this year, if you look into the syllabus, which I suggest you guys read, how many of you guys read the syllabus, honestly? I had this like bet with my wife about this. I was like, none of them are going to read this anyway, because I worked on it for like 15 hours or more. But I was like, nobody's going to read this. Right? But none of you guys read it, right? Like, am I right?
Well, not yet.
Okay, not yet. That's fine. I just knew that nobody, my wife was like, I read syllabus. Well, I'm like, yeah, you're like a straight A OCD student. But read the syllabus. It'll really distill this all down into what it is that we're trying to achieve and what you need to know. And in there is also the UQuick syllabus. And so that will be after these 4 weeks, that will be following up at that time. And that's curriculum. It's ethnographic observation. You'll be on the wards. You'll be speaking with patients about patient safety and quality improvement. And it's very, very good team leaders doing that. Rachel Lucatordo, internal medicine, and Ulfat Sheikh, pediatrics, as well as Patrick Romano, who's our fearless leader, who is both IM and peds. Overachiever. So the last thing is there's a Facebook group where if you guys are interested in this type of stuff, I post articles in this Facebook group that I think are salient. I don't like overload your feed with stuff. Do I? Does anybody follow it? I don't. I try not to. It's not overloading your feed, is it? I don't. Anyway. So the idea is that if you guys follow this, you'll get information about current affairs going on in the health policy realm. big picture type stuff. And also, that way, I can potentially keep in touch with you if you do become president. And then, this is a question I always like to ask. How many of you guys are on Facebook? Raise your hand. How many of you guys are on Twitter? Nice. Okay, there's also a Twitter group, too. Last year, I found that none of the med students were on Twitter. They were all on Facebook. Well, most were on Facebook. They were all on Instagram. But we don't have an account on the gram because you can't post links, and so that's why. Do you guys have any questions for me? Yes, sir. Sorry? Oh, sign in here? No, I know who you are. We got some emails from some people who said they couldn't make it, and that's fine. There's no sign-in sheet. Any other questions at all whatsoever about anything that we talked about? Yo, yes, sir.